The vertebral column. The major divisions of the adult vertebral column, you'll notice 4 spinal curves. 7 cervical vertebrae constitutes the neck and extends inferiorly to the trunk. 12 thoracic vertebrae form the superior portion of the back. Each articulates with 1 or more pairs of ribs. 5 lumbar vertebrae form the inferior portion of the back. The 5th articulates with the sacrum, which in turn articulates with the coccyx. These are the normal spinal curvatures. They include the cervical curve, the thoracic curve, the lumbar curve, and the sacral curve. This is an illustration demonstrating those curves. Again, the cervical curve, the thoracic curve, the lumbar curve, and the sacral curve. You should be familiar with those curvatures. Abnormal spinal curvatures can occur. Several abnormal distortions of spinal curvature may appear during childhood and adolescence. Kyphosis is an exaggeration of the thoracic curvature. Lordosis is an exaggeration of the lumbar curvature, and scoliosis is abnormal lateral curvature. Here are some examples taken from your text of the various abnormalities that can be seen in the spinal curvature. The first to your left is an example of kyphosis. In the center is an example of lordosis, or an exaggeration in the lumbar curvature. And then finally, scoliosis is lateral curvature of the spine. This is an illustration of the vertebrae. Again, this illustration is taken out of your textbook that looks at the vertebrae that are involved in the vertebral column. You should be able to know the bony landmarks of these vertebrae, and you should be able to identify specific characteristics of the cervical vertebrae, the thoracic vertebrae, and the lumbar vertebrae. For example, some processes that you'll have to identify in your laboratory assignment will include the spinous process, the superior articulating process, transverse processes, and vertebral body. Vertebral body is the point of most significant support. Also, you should notice there are inferior articulating processes as well, just as there are superior articulating processes. You should also appreciate the transverse process. You should also look at the point of how these vertebrae are stacked upon each other. In a lumbar puncture, it's the ability to guide a needle into this intervertebral space to draw spinal fluid. Vertebral anatomy. Each vertebrae consists of 3 parts: a vertebral body, a vertebral arch, and an articulating process. You should be able to identify these structures. Spina bifida. Spina bifida occurs during the 3rd week of embryonic development. The vertebral arches form around a developing spinal cord. In a condition referred to as spina bifida, a portion of the spinal cord develops abnormally, and as a result, the adjacent vertebral arteries do not form. Because the vertebral arches are incomplete, the membranes or the meninges that typically line the dorsal body cavity will bulge out. This is the most common developmental abnormality of the nervous system, occurring at a rate of about 4 cases per 1,000 births. Let's just go back to that previous slide of the vertebrae. Again, the vertebral arch, or this portion of that vertebrae in spina bifida, does not develop, and it leaves this area open and that area of the spinal cord exposed. This is a view of the cervical vertebrae, up-close illustration of the neck, which would include the 2 superior articulating vertebrae, one being the atlas, the other being the axis. It's important that you be able to recognize these two bony structures and understand the significance of the bones. The atlas is actually fixed to the occipital bone. The point of articulation here, the articulating facets, actually sit at the inferior aspect of the occipital bone. The axis, which is the second cervical vertebrae, sits under the first. There is a projection that gives you an appearance on this illustration as a thumb. There's a projection over which ligaments will pass. These heavy ligaments help to hold this bone in place. Now, this is important because since the first cervical vertebrae is affixed to the base of the skull, when we turn our heads, all of the stress and the pressure of supporting and turning our head rests on this little bone referred to as the dens. This is why a neck, when a severe cervical fracture has occurred, it's because of the risk of damage to this bone, the dens. If a crushing injury destroys the den, then the person is typically paralyzed from the neck down. Now, there can be some other causes of such a traumatic event as well, but to make my point, I will at this point just recognize the fact that if damage occurs at the axis, then this individual will have a cervical spine injury that could result in paralysis involving all four extremities. Again, on the lateral view, you can see this illustration of cervical vertebrae. This is C1, this is C2. Again, C1 sits at a more superior position. The superior articulating facets will support the occipital bone. And again, for the rotation of the head, C2 has a thumb-like projection referred to as the dens, and this bone actually is able to rotate on top of the other. These are some regional differences in the vertebral structures. The slide illustrates, or actually demonstrates, three different types of vertebrae: the cervical vertebrae, thoracic vertebrae, and the lumbar vertebrae. You should be able to differentiate these three types of vertebrae. One of the first, most obvious differences is the bifid spinous process. In the cervical vertebrae, you have a bifid spinal process. In the thoracic vertebrae, you have a single projection, and you can see the difference in the lumbar vertebrae as well. It's broader, it's thicker, because it supports the majority of the body weight. Again, you should be able to recognize these three vertebrae: cervical vertebrae, thoracic vertebrae, and lumbar vertebrae. There's another phenomenon referred to as whiplash and or whiplash injury. If you change position suddenly as it relates to your neck, as in a fall or during a rapid acceleration, takeoff, or deceleration, such as in a car crash, the balancing muscles are not strong enough to stabilize the head. The dangerous or partial complete dislocation of the cervical vertebrae can result with an injury to muscle and ligaments and potential injury to the spinal cord. The term whiplash is used to describe such of an injury because the movement of the head resembles that of cracking a whip. The atlas and the axis we've already alluded to in the earlier slides. These are basically the first two vertebrae on the cervical spine, the atlas being the first vertebrae and the axis being the second. The atlas articulates with the second cervical vertebrae, the axis. This articulation permits rotation as you shake your head no. The axis during development, the body atlas fuses to the body of the second cervical vertebrae called the axis. This fusion creates a prominent dens or odontoid process in the atlas. I would know both words to describe this fusion point, the dens and the odontoid process. Again, the odontoid process is almost like a finger-like projection. It's actually very small and smaller than your little finger. But this bone provides a tremendous amount of support for the head and neck. And again, the ligament, the transverse ligament that is a part of this surrounds that area. Now, the lumbar vertebrae bears most of the weight. Massive spinous processes that provide surface areas for attachment of the lower back and muscles and reinforcement and adjustment of the lower lumbar curve. This is an illustration demonstrating to you the lumbar curve and the large bones of the lumbar vertebrae. You can see the significant mass of the vertebral body, much larger than the rest. You also can see not only a spinous process, but you also see a superior articulating facet and a superior articulating process. You also see this transverse process as well. You still have an opening for the spine, the vertebral column, the significant body here, but also you see significant bony network at the posterior aspect of the vertebrae as well, which would include the spinous process, the inferior articulating surface, and the transverse process. The sacrum provides an extensive area of attachment of muscles, especially those that move the thigh. The superior articulating processes of the first sacral vertebrae articulate with the last lumbar vertebrae. This is an illustration or picture of the sacrum. Again, a very unique bone in its appearance, has a number of holes referred to as foramina, and we know what foramina are. They're tiny holes where blood vessels and nerves will pass. We see a series of these little holes for the nerves that involve the motation and movement of the lower extremities will pass through these structures. There is also the coccygeal bones. These are little, small, tiny bones that cause some discomfort in individuals who fall backwards and land on the derriere. At times, these little bones, which are typically fused, can break. They can be very painful, but there's not really any significant treatment you can do for that. So you should be able to identify these prominent structures on the sacrum. The coccyx, small coccyx, consists of 3 to 5, typically 4, coccygeal vertebrae, which generally begin fusing at the age of 26. The coccyx provides a point of an attachment for a number of ligaments and for muscles that constrict the anal opening. The other part of the axial skeleton that's important is the rib cage. This protects the heart, the lungs, and the thymus, and other structures in the thoracic cavity. It serves as a point of attachment for muscles involved in respiration, maintenance of position in the vertebral column, and movements in the pectoral girdle and the upper limbs. The rib cage, the skeleton of the chest, or the thoracic cage, provides bony support to the walls of the thoracic cavity. It consists of thoracic vertebrae, the ribs, and the sternum. This is an anterior view of the rib cage. You can appreciate the connection between the ribs and the sternum. There's the arrow. These are the ribs. They connect posteriorly to the vertebral column. Anteriorly, as you can see, they connect with cartilage, which attaches to the midline at the sternum. This is a posterior view showing a point of attachment for the ribs posteriorly. Ribs are elongated, curved, flattened bones that originate on or between the thoracic vertebrae and in the wall of the thoracic cavity. Each of us, regardless of our gender, has 12 pairs of ribs. The first 7 are called true ribs, or vertebrosternal ribs. They reach the anterior body of the walls and are connected to the sternum by a separate cartilaginous extension. This is referred to as costal cartilage. Beginning with the first rib, the vertebrosternal ribs gradually increase in length and in the radius of the curvature. Ribs 8 through 12 are called false ribs because they do not attach directly to the sternum. If you look at the previous illustration, as you can see, these ribs don't attach directly to the sternum by cartilage. They actually attach from cartilage to the sternum. You see that in all of these cases. This is a picture illustrating to you the rib. You should be able to identify the landmarks of the rib, the tubercle of the rib, the head of the rib, the body of the rib, the costal curve, the costal angle, articulating facets, and the tubercle. You should be able to identify those portions of the rib. When chest surgery is performed on the heart, lungs, or other organs in the thorax, it typically involves entering the thoracic cavity. The mobility of the ribs and the cartilaginous connections of the sternum allow the ribs to be temporarily moved out of the way. There's an instrument referred to as rib spreaders. These are used to push the ribs apart in much the same way as you would see a jack lift a car off the ground. And more extensive access is necessary. Cartilage of the sternum can be cut and the entire sternum folded away, so it would leave a significant room for the surgeon to work. Once replaced, scar tissue reunites cartilages and ribs and heal fairly rapidly. A diagnostic procedure that's performed either in a clinical setting or an outpatient setting is referred to as thoracentesis. After the thoracic surgery, chest tubes can be inserted through the wall of the thoracic cavity to permit drainage of fluids. To install a chest tube or to obtain a sample of pleural fluid, a physician must penetrate the wall of the thorax. The process is called thoracentesis. Typically, an anesthetic agent is injected in a space between the ribs. The needle is then inserted, typically passed directly over the superior aspect of a rib, and then enters into the pleural cavity. Significant amount of fluid, drainage, blood, or even air can be retrieved by these methods. Penetration at this location avoids damage to vessels and nerves. And when I say that, the inferior aspect of the rib is where the blood vessels and the nerves run. That's the costal groove. So the needle should be inserted above the rib, directly above the rib, which will allow the avoidance of damaging blood vessels and nerves. In the next lecture, we'll go through the pectoral girdle, which involves the upper limbs, the pelvic girdle, which involves the lower limbs. Thank you.